So today the clinical side lecture now. I am Dr. Muhammad Afnan. I am consultant physician in medicine. So we are going to discuss a clinical aspects of renal system as you are. Uh, we have lectures in this month from previous lectures are regarding acute kidney injury, chronic injuries, vascular diseases of kidneys, and polycystic kidney disease. If you have any question, you can type on chat box, or especially at the end of the session, we will have a question and answer session too. So chronic kidney disease, you are seeing in the picture, there are multiple cysts in a kidney, and epidemiology of polycystic kidney disease is included. 12.5 million people in our world is suffering from polycystic kidney disease. By definition, polycystic kidney disease is a subset of renal cystic disorders in which cysts are distributed throughout the cortex and the medulla of the kidneys. As you know, kidney has two parts, cortex and medulla. But these cysts are ill-defined and they are scattered throughout the cortex and medulla of the both kidneys. Numerous, usually multiple cysts, and are fluid-filled, resulting in a massive enlargement of the kidneys. In a clinical aspect, if kidneys are palpable in a patient, you always or most of the time you suspect the patients have a young patient or adult patients, or maybe in children if kidneys are bilateral palpable. Think about the other causes. As you think other causes of the kidneys, one of the top is polycystic kidney disease. No, there are two types of polykidney disease. One is autosomal dominant polycystic kidney disease, and this is a most common form of the polycystic kidney disease, which is, as you know, is a congenital and is a autosomal dominant polycystic kidney disease. And less common, this is autosomal recessive polykidney disease. As a genetics, you know about there are two types of disorders. One is autosomal dominant and other is autosomal recessive. Same way, there are two types of polycystic kidney disease: autosomal dominant polycystic kidney disease, and other is autosomal recessive polykidney disease. Uh, so there are two major forms of polycystic disease are distinguished by pattern of inheritance. ठीक है? Adult polykidney disease, which is autosomal, is have a chance of 50/50, and autosomal recessive, which have a chance of 1 in 4. It means if parents of uh, children are affected with the genes of autosomal disorder having a polycystic kidney disease, there are 50/50 chances that their children, their kids, are affected with the polycystic kidney disease. And as such, in autosomal recessive disorders, they have a 1 in 4 chances. Uh, they have a 1 in 4 chances that they have suffering from autosomal recessive disorders. No, there's a difference between the two disorders. One is autosomal dominant kidney disease is most common, and autosomal, in contrast, autosomal recessive polykidney disease is most severe form. Onset in autosomal dominant is usually more than 30 years, but autosomal recessive disorder present in infants and children. Half of the patients suffering from adult polycystic kidney disease end up with a end-stage renal disease at the age of 60. But in autosomal recessive polykidney disease, patients usually go in a renal failure in early part of the life. Autosomal polycystic kidney disease is involved in multiple part of the bodies. So cysts are present in kidneys, in liver, in spleen, or in a cerebral aneurysms are present in autosomal polykidney disease, but hepatic disease is more severe, can which lead to a death in autosomal recessive polykidney disease. So this is a difference between autosomal dominant and autosomal recessive polykidney disease. Now, pathophysiology of autosomal polykidney disease is they are usually bilateral disorder and increase in the number of the cysts which may lead to a end stage renal disease. As I told, their cysts are usually multiple and multi-organ involvement are present. So kidney cyst, hepatic cyst, cerebral aneurysms, cardiac valvular and abnormalities are also associated with this polycystic kidney disease. Two defects are usually present in the genetics, which you are learning genetics. Effect on the polycystic kidney disease is in gene 1 and in gene 2. PKD gene and PKD2 are expressed in most organ and tissue of the human bodies. So these protein have encoded by PKD1 and PKD2, and polycystin 1 and polycystin 2 seems to be a function together and regulate the morphological configuration of the epithelial cell. So in short, PKD1 and PKD2, these are the two basic genes which are defected in multiple organs of the body, which lead to formation of multiple cysts in kidneys, liver, spleen, brain, and heart. I think I summarize in is in a good way. So next next pathological changes occur after formation of a cyst is a decrease in the urine concentrated capacity of the bodies lead to a stimulus for increased secretion of vasopressin, plasma vasopressin level, and increase in the may attempt to compensate this ADH level, vasopressin level is increased due to compensatory pathway which lead to increase due to accumulation of fluid in the bodies and in the development of a new cyst as fluid is retention in the body. So cysts are filled with a lot of fluid and high fluid in retention lead to hypertension and renal insufficiency. So this after formation of a cyst, the body ability, the kidney's ability to concentrate a urine is lost, which lead to a stimulus to increase in the level of vasopressin ADH level in the body is high, which lead to increased fluid retention in the bodies and in the cyst causes hypertension and renal insufficiency. This is the pathophysiology of hypertension in a body. So cyst-induced bilateral renal ischemia, when high level of fluid is accumulated in a cyst, leads to a renal ischemia. Subsequent activation of the renin-angiotensin endothelin system is an important factor in the initiation of hypertension and polycystic kidney disease. When the high level of fluid in the cyst lead to activation of renal angiotensin system, and lead to excessive angiogenesis and on increase in the blood supply of the cyst may lead to a traumatic bleeding into a cyst or causes expand which causes severe pain and bleeding in the cyst and causes hematuria or causes gross hematuria which causes severe pain in the bilateral kidneys and in the lumbar region of the patient. So, in summary, when the cyst is filled with a high level of fluid, this causes renal ischemia, and ischemia lead to increased angiogenesis in the cyst, which causes engorged blood vessels to a high blood flow to the cyst, and if it's traumatic, and then lead to a blood in the cyst, and lead to a severe pain in the kidneys, and if the cysts are rupture in the collecting system, it causes a gross hematuria. Patient present with blood in the urine. So this is a sign and symptom of polycystic kidney disease. Patients usually present with the abdominal pain in the flanks or in the back, typical lumbar region pain, pain in the back which radiated in the front of the abdomen, and is most universally present in the patient with adult polycystic kidney disease. So pain is the most common symptom of a patient with polycystic kidney disease. Sometimes patient can present with a dull, aching or uncomfortable sensation or heaviness in the right hypochondrium. Right hypochondrium may result from a large polycystic liver. So patient can present a dull, aching or uncomfortable in the right hypochondrium. Right hypochondrium region is just below the right rib, lower ribs. This is due to a large polycystic liver. As I told, a polycystic kidney, it doesn't mean it only involve kidneys, but it also involve liver, heart, brain, and spleen. Pain, pain is usually more severe, as I told you, when the pain one of or more cysts are become very large. So which I told you previously, due to increased blood supply to the dead cells, lead to a traumatic rupture, and patient can present with bleeding with urine or gross hematuria. UTI, urinary tract infection, acute pyelonephritis, and infected cyst, perinephric abscesses, these are the all complication of polycystic kidney disease. UTI, urinary tract infection, acute pyelonephritis, infection of a cyst, and perinephric abscess. Other is berry aneurysms. The berry aneurysm is formed in the circulation of brain. When there is increase formation of aneurysm may lead to a rupture of a aneurysm in the brain. Patient can present with a subarachnoid hemorrhage and intracerebral hemorrhage, nephrolithiasis, and renal colic. Due to increased retention in the urine and increased fluid retention in the cyst lead to a formation of renal stones and which lead to a renal colics. Rarely are incidental hypernephromas are may be present, but this is a very rare manifestation of the polycystic kidney disease. Mainly, the patient present with pain in the lumbar regions and hematuria, third symptom of UTIs, and other manifestations are aneurysm in the brain lead to a subarachnoid or intracerebral hemorrhage, stroke, and fourth is renal stone, formation of renal stones and renal colic. These are the main presenting feature of a patient with polycystic kidney disease. So, examination of a patient with adult polycystic kidney disease may show the following sign. Patient have a hypertension, especially in adult patient. If young patient present with the hypertension, has a long list of the causes of the young patient with hypertension. Polycystic kidney disease is one of the common cause of hypertension in young adults. When you palpate the abdomen, there are bilateral flank masses are palpable in the lumbar regions. Or patient may have hepatomegaly. Hepatomegaly is nodular because they are nodular is because there are multiple cysts which are palpable on the abdomen examination. In severe polycystic kidney disease, rarely symptoms are related to renal failure. Patient have a paler, dry skin, edema as a symptom of chronic kidney disease. Patient can present with these symptoms if patient have a long-standing history of hypertension. So patient can present with the symptoms of chronic kidney disease. But typical symptoms of sign of polycystic kidney disease is hypertension and bilateral renal masses are palpable. Now we are going to how to investigate a patient with polycystic kidney disease. Routine laboratory studies include serum calcium, phosphorus level, CBC count from a cyst or CBC count from a blood. Both are important. If CBC count in a cyst is increased, you can say a patient have a hemorrhagic cyst. If CBC, if a blood show increased hemoglobin, it may be due to a high excretion of erythropoietin in a cyst can lead to a polycythemia or patient may have anemia. If patient have a long-standing history of hypertension which lead to chronic kidney disease, so patient can present with the anemia. But usually the most common presentation of patient is increased HB level, polycythemia, and the urine analysis show proteinuria and some sort of epithelial cell cost are also present, or patient may have a urine positive for blood. Hematuria is also a presenting feature of that. If patient have a system sign of UTI, urinary tract infection, so go for urine cultures, which is important. Genetic testing, as I told you, polycystic kidney disease is a genetic disorder. So genetic testing is performed, in which the major indication are from genetic screening in young adult with negative ultrasonographic finding who are being considered as a potential kidney donor. So usually in our setting, we are not going for every patient with genetic testing. We usually diagnose the patient with ultrasound finding of a patient with cyst, which I show you in later on slides. So genetic testing is only performed in such a patient in which the ultrasonic findings are negative. So this is a typical ultrasonic ultrasound finding of a patient with show multiple cysts, one, two, uh, sorry, one, two, three, four, five, six. These are the multiple cysts which are present on ultrasound of a patient with polycystic kidney disease. So, best screening test for diagnosis of a polycystic kidney disease is ultrasound of abdomen. Ultrasound ultrasound always shows multiple cysts in kidneys or cyst in the liver or cyst in the pancreatic and cyst in the spleen can be seen in the patient of ultrasound finding in a patient of a polycystic kidney disease. CT scanning is not a routine, but when a cyst is infected or a stone is present and suspected other causes of um, polycystic kidney disease is not found, so we go for a CT scanning or MRI scan of patient with polycystic kidneys. But uh, best screening, as I told you, best screening test for diagnosis of a polycystic kidney disease is ultrasound of abdomen, not a CT, not MRI, and not MRA, but CT scan and MRI is an alternate choice for patient with polycystic kidney disease. At the end, MRA, magnetic resonance angiography, which is a new technique. Previously, invasive angiographies are performed, but now let a magnetic resonance angiography, which is performed in a patient with when suspected intracranial aneurysms, such as berry aneurysms, are suspected, or patient present with a intracerebral subarachnoid hemorrhage. Then we go for magnetic resonance angiography, which show the multiple aneurysm in the cerebral circulations. This is a diagnostic criteria of a patient with ultrasonic on the basis of ultrasonic finding. At least two cysts in a kidney or one cyst in each kidney in a at-risk patient younger than 30 years. So this is if a patient which is younger than a 30 year, two cyst in a kidney, या तो उसकी किडनी में दो cyst एक किडनीज में दो cyst हो या फिर दोनों किडनीज में एक एक cyst हो 30 ईयर से कम एज का पेशेंट है उसकी या तो एक किडनी में दो cyst हो या दोनों kidneys में एक एक cyst हो. On that date, we can say patient has suffering from a polycystic kidney disease. If patient is above 30, 30 to 59 years, two cysts in each kidney, if, if present, then we say is a polycystic kidney disease. Or if the patient is more than 60 year or older, four cysts in each kidney is present, then we diagnose or say this patient is suffering from a polycystic kidney disease. It's a very important diagnostic criteria, and you have to remember in the especially in the final year MBBS, always ask in the examination the diagnostic criteria of polycystic kidney disease. So remember it, if patient is less than 30 year, टू सिस्ट या तो उसकी किडनी में एक किडनी में दो सिस्ट हो या दोनों किडनीज में एक एक सिस्ट हो. If patient is 30 to 59 year each of age, then two cysts is mandatory in both kidneys for diagnosis of polycystic kidney disease. Or if patient has more than 60 or more than a 60 year of age, four cysts in both kidneys are present, then we say the patient is suffering from a polycystic kidney disease. So this is a explanation of this previous criteria, which we'll discuss in the further complicated criteria we discuss in the third year, fourth year or final year MBBS. Uh, yeah, as I discussing previously, MRA, the indication of MRI is if a patient have a family history of a stroke or an intracranial hemorrhage, aneurysm or hemorrhage, development of symptom suggesting an intracranial aneurysm, go for MRA, magnetic resonance angiography of brain circulation, and job or hobby in which a loss of consciousness may be lethal. This is not so important, but MRA is always suggested if a patient have a family history for stroke, adult patient with stroke, or patient have a polycystic kidney disease. So we go for MRA of uh, brain circulation, which may show a many aneurysms. This is a dramatic picture of a patient with intracerebral MRA imaging show multiple aneurysms are present as shown in this arrow. Here is an aneurysm, here is an aneurysm, and these are when aneurysm there are always a multiple aneurysms are present in multiple vessels of the brain, which easily rupture and lead to a hemorrhage or hemorrhagic stroke or especially subarachnoid hemorrhage with between the meninges of the brain is the most common complication of perianeurysm in patient of polycystic kidney disease. At the last, we have a management plan. Here we only discuss with you a management plan of patient with polycystic kidney disease, and management detail is I will discuss in the fourth year final year MBBS. So basic management plan of this as of polycystic kidney disease. Remember one thing: polycystic kidney disease cannot be curable or treatable. We only prevent his complications so that, or if patient can develop a renal failure, we can treat a renal failure. Or if patient have his complications such as hypertension or chronic kidney disease, aneurysm or hematuria, UTIs, pyelonephritis, we can treat these complications. But polycystic kidney disease as it's the genetic disorder, we can't treat or to cure these disorders. So management goal number one is control of the blood pressure with the use of ACE inhibitors, ARBs, or even a calcium channel blocker can be used. ठीक है. Control abnormalities related to renal failure. Third goal is treat UTIs if present. Fourth goal is treat cystic infection if patient develop perinephric abscess or pyelonephritis. Then we treat with antibiotics such as ciprofloxacin and levofloxacin, trimethoprim or chloramphenicol or clindamycin. are the choice for us. Treat hematuria if present, possibly analgesic therapy, copious or oral rehydration as a supportive treatment for our treatmental hematuria, and reduce pain from can be used from analgesics due to increase the large size of kidneys usually causes continuous dull pain in the lumbar region, which can be treated with analgesic. Prevent cardiac valve infections or other intrinsic valve diseases if present. The supportive treatment can be done for this. So treatmental goal number one and most important is control of the hypertension. Your blood pressure systolic or in young adult can be less than 130 by 90 is a goal. Use of AC inhibitor or ARBs or calcium channel blocker. Surgical options are usually have a very limited role in the management of polykidney disease. Surgery is only indicated when there is a cyst, a large cyst, very large size in the kidneys, and when there is a very large size, there is risk of a rupture. So this cyst can be excised, and if a cyst is infected either in the renal system or hepatics, or it not responding to a conventional antibiotic therapy, we can excise these cysts, cysts surgically. Open or fiber optic guided surgery m- nowadays, as increased intervention of via endoscopy. We prefer fiber optic guided surgeries if a need of a cyst excision or drainage of a cyst is necessary. If one kidney is which is very much inflamed and have a lot of cyst, we can go for a nephrectomy, total kidney removal one side. These are options which depend on the further patient demand and further medical response. Partial hepatectomy, if a cyst in the liver is enlarged massively and causes a massive hepatomegaly, then we go for a partial hepatectomy. Is infected part of the liver is removed. So, if multiple cysts and of cysts present in the liver will lead to a liver failure, or even a kidney failure. We go for a liver transplant and even for the kidney transplant. Patient with adult polycystic kidney disease is progress to ultimately usually more than 90% patient with adult polycystic kidney disease go for end stage renal disease in a subsequent 10, 20 or even 30 years depend on the aggressiveness of the disease. So if the patient develop a chronic kidney disease, then we have go for renal replacement therapy in form of hemodialysis or peritoneal dialysis or even renal transplant. These are the end stage management options available for polycystic kidney disease. So at the summary of this lecture is 12.5 million people are suffering from a polycystic kidney disease. There are two types: adult polycystic kidney disease and autosomal dominant, which is and other is autosomal recessive polykidney disease. Autosomal dominant polycystic kidney disease is asymptomatic, most common form, and asymptomatic to a more than 30, and sign symptom usually patient present with pain, hematuria, hypertension, palpable kidneys with nodular surface and nodular hepatomegaly, berry aneurysms, and mitral valve prolapse can occur. Diagnosis is very important. Number one diagnostic investigation is ultrasound of the abdomen, other clinical finding, and number three is a family history and family screening is important. And then no specific treatment, no specific medication are available except we go for a supportive care, supportive and the treatment of complication is necessary. So thank you for your listening. If you have any question, you go for you write a question in the chat box. I will try to answer all your question, and later I will ask a question from you, and then you have to answer. So I am waiting for your questions in chat box. Any questions, student? No question. Any question? If there is no question, I think you could not listen to me or no questions, students. Please ask any question if you have any question.